anything if you like. Friends, we have a very important topic tonight to discuss. It's going to be non-alcoholic fatty liver disease. It has been rechristened as metabolic dysfunction associated liver disease. Lot of things are changing on that scenario now. There is a new name for NAFLD. There is also a new name for steatotic hepatic liver disease, and there is also a new name for NASH to MASH. Okay, so everything now is based and centered on metabolism. When we talk about diabetes, I think 20 years we've been talking about diabetes now in this forum, at least with some of you, and you would remember that the most important thing that stands out in the pathophysiology of diabetes is insulin resistance. It is of great significance because everything revolves around insulin resistance. Whether it is hypertriglyceridemia, or it is low HDL cholesterol, or it is very high amount of free fatty acids, or it is high atherogenicity of the blood in a patient of diabetes, and the various things like metabolic syndrome, obesity, type 2 diabetes, hypertension, everything is interlinked through a common link, and the common thread that runs through all of them is something called as insulin resistance. We have a very esteemed speaker today, Dr. Hemi Soneja, who will be speaking on this very important topic. What I want to convey to all of you is, if you have a patient of obesity, or if you have a patient of type 2 diabetes, or if you have a patient who has been diagnosed as a case of fatty liver on routine ultrasonography, or even if you have a patient who is young but has a very high family history in the tree of hypertriglyceridemia, of atherogenicity in the family, of premature CVD, kindly investigate these patients for insulin resistance. I am sure ma'am will bring out the importance of this important topic, and everything then boils down to the liver. It is the organ which suffers the maximum, but also the organ which gives you the first indication of a brewing disorder, which if we take care in the early stages will go a long way in preventing complications. I would request Dr. Hemi Soneja ma'am to start her lecture. She has already introduced herself. My only request to all of you is to please keep decorum during the talk. For me personally, it is a topic which I love, and I have spoken on this topic in this very forum, although it was an impromptu talk as Dr. Viveka failed to turn up. And I would request ma'am to start her talk, and I would request all of you to carry home some important messages from this and be interactive during the question answer session. Over to Dr. Hemi Soneja ma'am. Number 872.
Okay. I'm audible, right?
Yeah.
So, talking about the new dimension and management of NAFLD. I'm going to try and keep the presentation pertinent because I know we have all the experienced doctors over here. We don't need to really look at the very basic stuff, but we'll get to the pertinent points so that we can discuss about them more. Now, as we were all talking about, insulin resistance, as we all know, is a common link for various metabolic conditions. So, be it type 2 diabetes or atherogenic dyslipidemia, NAFLD, all of them they have a common factor, the insulin resistance, and the prevalence of that is quite high in India and worldwide as well. And this is something which is continuing to increase, and we don't really see it getting better in the near future. NAFLD, it is the neglected epidemic. So I think, a lot of times you will have people who will come up and say, okay, हाँ मैम फैटी लिवर तो मेरे को है ही grade 1, grade 2 तो सबको ही होता है. So even just because it is very common does not mean it is normal to have. It is associated with a lot of these metabolic problems in the long term, which if addressed well on time, we can modify the disease process further on. And a lot of times people think that liver issues only in people who have problems with alcohol intake. It is not like that. So when we look at issues with liver failure, liver cirrhosis, actually fatty liver tends to be one of the very non-alcoholic fatty liver disease actually tends to be one of the most common causes of that. So as you can see here, in the whole spectrum, we have the normal liver, then we have the steatosis, which is really fatty liver without inflammation, and then we have steatohepatitis, meaning there is an inflammation along with the hepatocyte ballooning and all of that. And then we have cirrhosis, which is, which shows increase in fibrosis leading to cirrhosis and increased risk of hepatocellular carcinoma. When we look at the comorbidities with NAFLD, who are the individuals at risk? So people with type 2 diabetes, obesity, dyslipidemia, high blood pressure, and PCOS. So PCOS now also is termed as metabolic ovarian disease. So it goes hand in hand with that type 2 diabetes thing, which these women are at a high risk of developing in future. This metabolic inflexibility contributes to that dysregulated glucose and lipid metabolism in NAFLD. So we have this increased lipolysis, which is leading to very high free fatty acid levels in the blood. There is that interference with the mobilization of free fatty acid into the liver. And that is where everything kind of goes haywire, and we have excessive accumulation of this in the liver. And also impaired movement and mobilization into the skeletal muscle because of the insulin resistance factor. And this NAFLD and insulin resistance may lead to systemic inflammation. So it is not just the fat which is a problem, it is a persistence of fat which leads to issues with inflammation, which then turns into fibrosis and cirrhosis further on. So in those stages where we still do not have fibrosis happening, before that we are looking at a stage which is reversible. And that is where we won't catch our patients. That is where we want to work on the disease modifying agents, and whether it is diet, exercise, combination of these things along with medications if needed. As we can see in this busy slide, NAFLD is a major precursor for cardiometabolic complications, whether we talk about insulin resistance or the cholesterol metabolism or the cardiomyocyte effect, the effect on the endoplasmic reticulum which interferes with the mitochondrial oxidation, and effect of that is adipocytes. So all of these things, they are all interlinked to each other. Now when we look at the association of the common comorbidities with NAFLD, including the metabolic syndrome, as you can see here, in US in general population, obesity was in 39.8% people. If we look at in people with NAFLD, 51% of them were the ones who were obese. With NASH, 81.8% of them were obese. With type 2 diabetes, as we can see, all of these numbers with type 2 diabetes, hypertension, dyslipidemia, metabolic syndrome, they're all higher and higher in people who are moving on to the right side of the spectrum. And the real world data reveals a huge diagnostic gap in NAFLD. And I think is not just about the diagnostic gap, but it's also about the treatment inertia also, which we see not just in patients but in physicians as well. We are so much used to seeing that fatty liver that we just fail to address that in the middle of all the other problems that we come up with. And when we talk about the NAFLD clinical presentation, so typically people are not going to come with any symptoms at all with it. And screening therefore becomes a very important step in terms of prevention of this thing long term. So it is usually picked up asymptomatically on a routine testing, whether it's a tolerance test or a occupational health check. And this is the reason why we need to get particular about the screening part. When we look at the ADA recommendations also, it talks about NASH and fibrosis screening being recommended in people with type 2 diabetes or pre-diabetes and elevated ALT or fatty liver. With ESC recommendations also, they recommend people who are at high CVD risk, including type 2 diabetes or metabolic syndrome. So AST-ALT ratio, it does not rule out NASH. One of the important things is, a lot of times we'll have patients who will be, Dr. Sahab, मेरा blood test तो मेरे बिल्कुल ठीक है. They'll come up with very high HbA1cs, 10 plus HbA1c, other blood tests are normal. And if they're having issues with very high fasting sugar levels, they have significant frontal obesity. When you tell them that clinically you seem to be at risk of having issues with fatty liver, you need to get an ultrasound done or you need to get a fibro scan done because of the kind of clinical picture you have, then my doctor blood test is okay. So this is what we have to make them understand. This is what we have to understand also, is that all these patients are not going to have abnormal LFTs to start off with. So they might have significant fibrosis and they still might not have elevated LFTs. So they might be normal in around 80% of NAFLD patients. So if we go by just the LFT report, we are going to miss out on a lot of these patients. So what we want to look at is the FIB score and the NAFLD fibrosis score. So FIB4 score, it's a very easily available score, available on Google. Of course, you can do your own calculations also, but I find the Google application pretty useful for that. It will be there on the next slide as well. So if we have somebody with a FIB score of less than 1.3, that practically rules out fibrosis. So we are looking at the age, AST, ALT and platelet count when we are calculating the FIB4 score. And we have the NAFLD fibrosis score or the NFS score. So whichever one we use, we want to look at whether they are falling in the low risk category, the intermediate risk category or high probability category. So FIB4 score less than 1.3 rules out fibrosis, so that comes in the low probability. More than 3.25 predicts fibrosis, so comes in the high probability. Anything in between will be intermediate. So FIB4 easily can be calculated on the Google application very well. And then FibroScan, it's a vibration controlled transient elastography. So the whole idea is that it is directly related to the tissue stiffness. And stiffer the liver, the faster the shear wave propagates. So as such, it's been seen that training for doing FibroScans is actually very easy and can be standardized very easily by very few training sessions for these conditions. It is very reliable in ruling out advanced hepatic fibrosis. Liver biopsy, of course, is a confirmative test, but it has its own hazards and side effects of course, bleeding, and it is an invasive procedure. But yes, it does help with establishing diagnosis of NASH. But yes, at the same time, there can be issues with sampling variability and inter-individual variability also in the scoring system. So not typically the first thing, of course, that you would go for, and something which typically the gastroenterologist will be doing or recommending. Now, what about role of salad and desire in management of NAFLD. So before we get to that, actually, we will be looking at what are the other options that we have for management of fatty liver. So we know that we need to prevent the progression of disease, and weight reduction, around 10% weight reduction is what is desired. More, the better. So whichever way we are being able to reduce the weight of an individual directly helps with the fatty liver issue. And that is the reason why a lot of these newer diabetes medications like SGLT2 inhibitors or GLP-1 agonists, if they are helping with weight reduction, they do have an indirect impact on fatty liver. But again, these medications, they are not indicated for everybody with fatty liver. With any other specific indications, yes, these agents are to be preferred for those individuals. And of course, pharmacological treatment options, as I was talking about, with regards to medications for diabetes. Now, when you look at the algorithm for prevention of cirrhosis, so we have these high-risk groups with pre-diabetes or obesity or type 2 diabetes or the ones with steatosis. So we want to look at the fibrosis risk stratification. We talked about the low risk and the high risk earlier, and when we look at the intermediate risk or the indeterminate risk category, these are the patients that we want to evaluate further with the liver stiffness measurements with the fibroscans, which can be easily done on an outpatient basis. Again, in that we are going to have people who are going to fall in 3 different categories. So low risk, indeterminate risk and high risk. In people who are falling in the indeterminate risk or high risk, we want to refer them to the liver specialist for additional investigations and management. People who are falling into the low risk category of that, so the LSM is less than 8 kilopascal. These are the ones which can very well be managed by the primary care team or the endocrinologist, and with the main focus on obesity management and CVD prevention for them. Now, this non-pharmacological approach, if we look at, really the spectrum of management tools that we have, we are talking about non-pharmacological and pharmacological. But actually, come to think of it, if we look at the efficacy-wise thing, the non-pharmacological approaches actually are paramount to management of fatty liver disease. If we don't have that in place, none of the pharmacotherapy is going to do a good additive add-on as a treatment. So this does make a cornerstone, it is a cornerstone in therapy for people with fatty liver. So diet, exercise, and in certain cases bariatric surgery if they are otherwise eligible or candidates for bariatric surgery. So weight loss and exercise, again, this tends to be a very interesting and an area where there is a lot of information out there, but there are a lot of myths and misconceptions also which people have. So what I would like to summarize is that around 10% weight loss is what is needed to help improve metabolic problems. It does not mean that 5% weight loss is not going to be of any use. But yes, 7 to 10% weight loss does help significantly, and weight maintenance tends to be a very important part of this process further on. With regards to diet, basically a hypocaloric diet with a reduction in daily calories by around 500 calories per day, plus exercise, independent of the macronutrient composition of diet. So it's not about just vegan diet or keto diet or some other Mediterranean diet specifically which is going to work for an individual. It's going to be about the total amount of calories an individual is consuming, and also every individual is going to comply with different kind of dietary changes that we recommend. If I have somebody who is totally vegetarian and we ask them to go on a keto diet and expect them to complete, fulfill their protein requirements with just vegetarian and plant-based things, it can be challenging for them. Similarly, if somebody is, fond of their non-vegetarian food and asks them to turn vegan, that is not going to work for them. So we have to individualize things with regards to diet for a particular person. There are a lot of studies which talk about plant-based diet for people with fatty liver, but again, not everybody is going to benefit with that. So as a clinician, it gets down to us to see which patient might actually do better on that. And there are certain, clinical things which you see. So supposing they say कि डॉक्टर साहब जब भी मैं दूध पीता हूँ मेरी शुगर एकदम बढ़ जाती है. So these are the kind of things that you want to kind of pick up on. So if somebody is already saying that they're having high sugars when they are consuming milk or milk product, then maybe yes, we do need to go down on that, and that's likely to help them. So keeping that part also into consideration. Now percentage of weight loss, as I was talking about, so 10% is ideal, but yes, anything above 7% does help with NASH significantly. So who would be the ideal patient to start with medications? So if we have somebody on early stages of NASH with a high risk of progression of disease, age more than 50 or metabolic syndrome, or already having issues with diabetes, what we want is that the medications for NASH, they should have reducing effect on fibrosis stage. So what is it that we have available right now, and what are the medications that we have, some data available on? So the list is big, but there is really not anything significant when it comes to, usability in clinical practice. Metformin, insufficient evidence, not beneficial. Vitamin E, very sketchy evidence with that also. PPAR gamma agonists. So with PPAR gamma agonists, they might not be, useful for treatment of fatty liver, but in people with diabetes who have fatty liver, they might actually benefit with addition of a low dose pioglitazone for better management of their diabetes. So that is one of those final things to know and remember. Not for the fatty liver, but because they have fatty liver, they are going to respond better to the low dose pioglitazone as an add-on for better diabetes control for them. So other agents, pentoxifilin, GLP-1 agonist. So GLP-1 agonist, as I was talking about earlier. So even though it is indicated here that it shows here insufficient evidence, but if it is causing significant weight loss for an individual, we do see improvement, and there are studies which do see improvement in the fatty liver part also. So if there is something which is causing weight loss, it is likely to help with the fatty liver. But that alone is not the indication for use of GLP-1 agonist unless there are other indications. So even with UDCA or so even with statins also, it is not something which has been shown to help improve fatty liver. Yes, it will help with the LDL levels, but it will not really correct the underlying abnormality per se for us. So semaglutide data in the clinical practice. So it's India's first NCE approved for atherogenic diabetes, diabetic dyslipidemia. And it is world's first NCE approved for NAFLD in 2020. So PPAR alpha and gamma, as we know. So PPAR alphas, they form liver, kidney, heart and muscle, and is implicated in the uptake and oxidation of fatty acids and lipoprotein metabolism. PPAR gamma, they are mainly expressed in adipose tissue with beneficial effects on glucose homeostasis. This is the one where our pioglitazone is working, PPAR gamma. So saroglitazar, it is a dual PPAR alpha and gamma agonist, and through activation of the transcriptional factors, it has reduced the triglyceride levels and also decreases insulin resistance, and as a result help with some degree of blood sugar control. And that is also one of the reasons why it does not tend to cause any issues with hypoglycemia. So in somebody for whom we are starting with fatty liver, we do not have to worry about the hypoglycemia part. So there is this data which was published in Cardiovascular Diabetology in 2019. It was a review analysis of 18 studies of semaglutide involving around 5,000 plus patients, in which it showed improvement in triglycerides, HbA1c reduction from around 0.7% to 1.6% reduction, ALT reduction of around 0.7% to 1.6% reduction, and reduction in small LDL by 20.3%. So when we look at this other study by Jan et al., it showed improvement in the glucose metabolism and the insulin sensitivity index. What it did not explain clearly is that how they assess the glucose metabolism. So insulin sensitivity, yes, with the insulin sensitivity index in the CLAP studies, it can be done, but it doesn't say clearly how the glucose metabolism was assessed here. So patients were randomized to semaglutide and placebo for around 4 months, and these were treatment-naive type 2 diabetes patients with a baseline HbA1c of 7 to 9%. And in this other phase 2 study, which was about the semaglutide efficacy in NAFLD, total number of patients of around 104 with NAFLD, and they were started off on semaglutide or placebo, and the study duration was around 14 weeks. And primary objective was change in the primary endpoints in full analysis set population from baseline to 16 weeks. So if we look at the first 1 year, this was about the percentage change in the ALT levels with semaglutide compared to placebo, which was significantly more with semaglutide. The absolute percentage change in the liver fat content, which was better with the semaglutide compared to placebo, and again percentage of patients with liver fat reduction by more than 20%. Yeah, and percentage of patients with liver fat reduction, which was much more in patients on the semaglutide group. Now, looking at the effectiveness of semaglutide in non-alcoholic steatohepatitis, this is the data from preclinical and clinical studies. This was biopsy-driven as well and involved patients in India. So, primary efficacy endpoints: the proportion of patients with decrease in the NA score at week 52 by at least 2 points spread across at least 2 of the NA's components. So we had the initial screening period, and then double-blind randomization, and then the follow-up period of around 12 weeks. So patients between 18 to 65 years of age were taken, and histological confirmation of NASH without cirrhosis was done. And NAS of more than 4 with a score of at least 1 in each component was taken. So primary endpoint, decrease in NAFLD activity score more than 2 was observed in 52.3% of patients without worsening of fibrosis at week 52 compared to placebo. And the p-value was significant over here, so less than 0.05. And when we look at the secondary endpoints as well, the mean percentage reduction of all secondary endpoints by semaglutide at week 52 was significant. So whether it was steatosis or hepatocyte ballooning, or the liver enzyme levels, and the lipid parameters as well, as you can see in the slide here. So another report of semaglutide in patients with non-alcoholic fatty liver disease. This was a prospective observational real-world study, and it aimed to determine the efficacy and safety of semaglutide in patients with NAFLD and diabetic dyslipidemia. So they looked at the baseline, and then at 24 weeks time, around 163 patients were screened, and around 101 patients completed the 24-week treatment. And when we look at the scores here, baseline and at 24 weeks, there was a significant improvement in the liver enzyme levels, the LDL levels, the triglyceride levels, significant improvement in that. The LSM score was much improved, the CAP score was much improved, and HbA1c as well, as we can see here. So at least a significant improvement in transaminases, LSM and CAPN, NAFLD patients with diabetic dyslipidemia, as we can see in this study. So this is now head-to-head comparison table. It is a direct comparison of the different common medications which are being used. So we have saroglitazar, we have obeticholic acid, and we have UDCA. So saroglitazar, as you all know, is a combined PPAR alpha and gamma agonist. It has a positive beneficial effect on insulin sensitivity, and it is indicated for NAFLD. There is a good reduction in the liver enzyme levels from baseline, and a significant reduction in liver fat. So we don't see any of that with obeticholic acid or UDCA for that matter, particularly the effect on the liver fat or NAS reduction. So with regards to side effects, it's pretty well tolerated. Some GI side effects can be seen at times, but less than 3% kind of a thing, which we see with saroglitazar. So it's been mentioned in two major Indian consensus studies for both ADD and NAFLD as well. So the Lipid Association of India expert consensus talks about it, and RSSBI 2022 expert consensus also talks about the use of saroglitazar for dyslipidemia management in type 2 diabetes. So to summarize, for NAFLD, weight reduction and lifestyle modifications are key elements, but yes, not possible to sustain for long period with that, but that is what is absolutely needed. Medications which we use, we want them to have reducing effect on both NAFLD activity score and fibrosis. And commonly used drugs like pioglitazone, vitamin E, metformin, UDCA, they are all off-label medications for NAFLD with very limited benefit. So saroglitazar is the first approved medication for NAFLD from India. It reduces the liver fat, liver enzymes, NAFLD activity score significantly. LAI 2020 and RSSDI 2022 expert consensus has mentioned the importance of saroglitazar and management of our patients with diabetic dyslipidemia and NAFLD both. So that brings me to an end of the presentation, and I will be happy to take any questions of yours.
Dr. Soneja, ma'am, please come.
लाइट जला देना बेटा.
Can we have the lights on, please? Yeah, thank you. Wonderful presentation, ma'am. There will be many questions. I am sure it's a very, very interesting topic and something very dear to GPs and specialists and to everybody. And Dr. Shubham was just holding a glass of beer. He should have the maximum questions to ask. I'll just start with one thing, ma'am. Something funny I found in the slide. There was mention of sorrow and there was mention of good. What does that mean, ma'am?
I think sorrow probably means good.
All right.
So,
actually, you know, the Zydus factory is in Ahmedabad, you know, and in Gujarati, when you ask a patient, "Kaise cho?" the patient always says, "Saro che." Everything is good. I'm good. Okay, so saro means good, but it means Gujarati. So it tells you the origin of the factory and the origin of the product. All right. All right. Wonderful presentation, ma'am. I wanted to ask you one thing, ma'am. In NAFLD, if the patient does not lose weight, he does not benefit at all. Do you agree with this?
yes, absolutely. So that is why I was talking about lifestyle modifications being the key, because if we do not have that in place, none of the medications are going to help. So when an individual really starts making the diet changes, we actually start seeing improvement in their metabolic parameters pretty soon after that. Even with the first meal change, we would start noticing changes in their blood sugar levels. And then further on, if they are continuing with that, we start seeing improvement in their metabolic parameters before the weight loss starts happening. With the weight loss, what we also have to look at is the fat reduction which we are talking about. It is not just the weight loss. So if somebody, say, they start doing a lot of, making a lot of diet changes, exercise, strength training, all of that, and they come back 4 weeks later, ma'am, मेरा weight वही का वही है, but हाँ मेरे को inch loss हुआ है. So if we are doing their body composition analysis as a baseline, and we repeat that again at 1 month time, and there is a reduction in that fat percentage, an improvement in muscle mass, we might not see a lot of weight change, but there are improvement in metabolic parameters. So yes, we want to see that fat reduction for us to be able to see that improvement in the metabolic parameters and fatty liver as a result.
I saw the list of medications which you said, ma'am, off-label use of medications, and it was very interesting to note some medications. You mentioned metformin. Metformin works on insulin resistance. You mentioned pioglitazone, which is, I would have selective PPR gamma agonist. It works on insulin resistance. You mentioned the other drugs like vitamin E and UDCA. UDCA does not work on insulin resistance, but still benefits NAFLD.
So it does not address the underlying problem with NAFLD. There might be some reduction of liver enzyme levels, but it is very temporary. As soon as you withdraw the medication, it is quickly back up. So it does not address the underlying disease process itself.
How does vitamin E help?
It actually does not. That's why we don't recommend the use of that. So a lot of those medications which were there on the list, they actually don't really help so much. That is why, when we talk about management of NAFLD, we really have very limited options which are effective.
Then you mentioned that lipaglyn, saroglitazone is a dual PPR gamma and alpha agonist. When it works on the PPR alpha angle, it works on the triglycerides, and when it works on the PPR gamma, when it works on the PPR gamma, then it works on the insulin resistance axis. I want to know one thing. We know that pioglitazone has a potential for fractures, especially in women, postmenopausal women, diabetic women when we use it. My question is, if we use saroglitazone in postmenopausal women with obesity, which is not an uncommon clinical scenario, does it have the same fracture risk?
So we don't know about the fracture risk as such as yet. As such, if we talk about pioglitazone also, that little bit of that increased risk, yes, is there. But typically now the doses that we use is much lower compared to how it was being used earlier. So earlier it was a very common practice for us to be using 15 milligram twice a day dose, so 30 milligram per day. Nowadays we typically don't use more than 7.5 or maybe maximum 15 milligram if somebody has responded well to 7.5 and we feel that they're not responsive to other agents and they do not have any other risk factor, that we would go to 15 mg. So as such with saroglitazone, we don't have that data regarding the bone fracture part.
Alright, as you mentioned about the NAFLD score and the usage of saroglitazone. Ma'am, at what score should we start using saroglitazone in NAFLD?
So, if we have somebody with a higher FIB4 score, we want to look at their fibroscan further on. And with the fibroscan, there are two things which we are looking at. We are looking at the CAP score and we are looking at the fibrosis score as well. So if somebody is falling into that moderate category or above, we should be using saroglitazone to help with the fatty liver.
Right. Ma'am, you mentioned that nearly 80% of people with NAFLD, they don't have transaminitis. Then how to proceed in these people?
So that is where we have, so fibroscan is a useful method. And again, a lot of it does get down to our clinical evaluation of the individual also. If we have somebody with significant truncal obesity, thin arms and thin legs, but they have significant truncal obesity, and say supposing they're diabetic with high fasting sugar levels, which is very highly indicative of issues with fatty liver. So it is not unusual for us to have people with fatty liver who are coming with डॉक्टर फास्टिंग शुगर मेरी तो 150 से नीचे कभी आती नहीं, लेकिन खाने के बाद मेरी कई बारी उससे भी कम होती है, so like 90 हो जाती है, 100 हो जाती है. So that is very typical of fatty liver, that they will have higher fasting sugar compared to the post-prandial ones. Even with, at times, people with fatty liver, how they would present at times is those episodes of feeling hypoglycemic. So, recently had this young girl, 36-year-old, single, was about to get married, and obese, and she had been having issues with this, significant episodes which she felt she was having hypoglycemia. She was not on any medications at all, she was not diabetic. Her HbA1c was 5.4, 5.5. She had a bit of calphosis, did her ultrasound, it showed fatty liver grade 2, and all her symptoms were really of that postprandial hypoglycemia. So she would have those fainting episodes, and she would feel very sweaty and restless and all of that. So changed her diet pattern, and within a week all her symptoms were gone. So that is what fatty liver does at times, is that there is a sudden spike in the blood sugar levels after food, especially with the with a simple carb meal. If a person is consuming, they will have a high spike and then sudden fall. So that spike might not be going above 140, but when that falls to 70 all of a sudden after that, it makes a person feel hypoglycemic.
Ma'am, you mentioned a lot of investigations, and for the larger audience who is present here, many of our GP friends who do not want to do so many investigations, two things if you have done in the blood chemistry. One is the low HDL cholesterol, and second is hypertriglyceridemia. If you get these two things, it is almost a surrogate marker of insulin resistance. Your comment on that, sir?
Yes, absolutely. Absolutely.
Right, ma'am. I open it to, I expected it from Dr. Sarath Gopalan, our pediatric gastroenterologist friend.
Thank you, Dr. Sushil. First, let me thank Dr. Sushil Chauhan, who was my PG, and I was an intern at Safdarjung Hospital in 1986, who invited me to the meeting. I may be the odd one out, but I'm passionately interested in this topic because we've done some work and we have published data. So, we published some data in 2017 in Indian Pediatrics, but some things I wanted to share with you. When it comes to children, I'm right now with the Rainbow Hospital, but this study was done with the Apollo Hospital when I was there. When it comes to children, only diet and physical activity works. Metformin is a no-no, it doesn't work. Vitamin E was a controversy for about 10 years. It still doesn't work. And what I want to know is, this drug, is there a potential for use in pediatrics? In those who don't respond to diet and physical activity?
So we are not using it in pediatric population as yet. But yes, liraglutide is something which we are using in younger kids, 12 years and above, for weight management. And as a result of weight management, indirectly, yes, it has the potential to help with the fatty liver.
Why I'm asking you this is because we analyzed 961 children in Faridabad schools, out of which 46% of them who were obese had fatty liver. That's almost 50% of those who were obese had fatty liver. But interestingly, about 17% with normal weight had fatty liver. So there's a genetic aspect. So the thin fat issue.
And plus, yes, you're right, the thin fat, which is a very big problem for us as Indians.
Exactly.
A lot of times we see these underweight girls with PCOS who who are coming in with these metabolic issues, and when you tell them that, oh, you are only consuming all carbs and you are not consuming any fiber, you're not having any protein or anything at all, they have that look on their face that why do I have to diet? It is not about a diet, it is about the healthy food which everybody needs. And as Indians, we do have that thin fat phenotype. And on the other hand, we do have those metabolically healthy obese also, who will be obese but they do not have any metabolic abnormality at that point of time. But again, that is also that controversial terminology, okay, whether it is an absolute thing or it is just a part, a stage in the continuum.
But there will always be a proportion of kids who don't respond to diet or physical activity. In there, with this drug work, somewhere somebody has to take a start in safety pediatric population. Maybe even 5 to 12 years. You may need to look at that.
Because are you using it?
I don't know.
Off-label use? Are you using it?
No.
Are you using liraglutide in the pediatric population?
No. Diet and physical activity, most of my children respond.
So you are not using any GLP-1 analogs?
No.
You are not using any thyroglitazone?
They are responding very well to diet and physical activity.
Can I ask you an honest question? What is the secret of your normal BMI?
Question. I don't do any workouts apart from something else.
We'll talk about it. We have a very learned pediatrician from South Delhi, Dr. Ashok Chakraborty, sir.
Thank you, sir. Thank you, sir. Excellent talk, man. As a pediatrician, I'm taking you from Dr. Sarad Viparan. He has been one of the persons whom I refer my gastro cases to.
Right.
Very often, when we do an ultrasound on kids for any reason, pain abdomen or just like, we get once in a while a report of fatty liver in a normal healthy child. Obviously, it's not NAFLD, obviously. What are the implications of that? And how do we go about it in managing it? That's my question.
So if we have a young kid who's having issues with fatty liver on the ultrasound, it is likely to be NAFLD.
Okay, agreed. Obviously, he's not taking drinks.
So
what's the reason for that, and how do we go about it and managing it?
And again, so genetics is going to play a significant role for these kids, and the lifestyle factors which will come into
Like
play
he said,
also.
exercise and all. And it will be the fruits. People say that fructose leads to NAFLD once in a while.
So it's the processed fructose syrup which is a problem, not the fresh fruits which is so much of a problem.
So the guys who are fruities, like they take lots of fruit all the time.
Sir,
does it happen with them?
Everything in moderation is important.
Moderation, that's the key.
So it's not going to be about a fruit diet all throughout the day and it's going to be enough to take care of everything for you. So everything in moderation is key.
Ma'am, the question Dr. Ashok Chakraborty, sir, just a minute. The question Dr. Ashok Chakraborty is asking, is this kid not a candidate for an extensive study on insulin resistance?
So, of course, as Dr. Chauhan was saying, that, is this child going to be a candidate for investigating for insulin resistance? So, this is what my take on insulin resistance for this child is. He has insulin resistance unless proven otherwise.
Naturally, test for that.
The testing that we have available for insulin resistance and things like that, so HOMA-IR index and all of those things, they are really not diagnostic or confirmatory. They are going to vary from one day to the other. So it really does get down to our clinical evaluation. So somebody with fatty liver has insulin resistance unless proven otherwise. So, and again, the interventions which we are going to be recommending are the ones which are going to work on the common root cause of the problem.
We normally recommend UDC.
So
normally we recommend that.
So it is really not going to be of much use without that diet and exercise, and even UDC, it doesn't really do much.
Dr. Sarath has and then we are coming to our eminent gastroenterologist, Dr. Shubha.
We all practitioners, we must keep the cost factor in mind. Genetic tests are prohibitively expensive. Please keep that in mind. So if we have alternatives, we must keep that in consideration. Sir, with you guys.
Thank you so much, sir. Thank you so much.
Ma'am, just a minute, and just to add to Dr. Ashok Chakraborty's question, should we also not investigate and clinically see these patients in detail for any lipodystrophy?
So lipodystrophy in the sense like, so dyslipidemia?
Yes, ma'am.
So dyslipidemia, so anybody who is coming with that fatty liver, yes, we need to evaluate their metabolic profile, their LFTs also, their HbA1c and fasting and BP blood sugar also, which should be checked. And for certain patients, it might actually be worthwhile doing a glucose tolerance test, which is going to give us more information compared to really doing those HOMA indices and stuff like that.
Right. Dr. Shubham is a wonderful gastroenterologist, and he comes here like any other member of the forum. Let's give him a big hand for that. Always coming to the forum, and he needs little more references from the forum.
I think the blessings are anyway taking care of that. So, ma'am, very intriguing to me was something you talked about hypoglycemia. So, first I need to understand, was it documented that the sugar levels fell?
So she had checked her sugars twice, and once it was 74, once it was 78.
Okay, and what was the time duration after she had a meal? Cerebral cortex comes up, and postprandial or fasting hypoglycemia in an adult patient, I am thinking about a neuroendocrine tumor all of a sudden. At 9 or 10 p.m. in the night, my sleep is gone. I am thinking about this patient. If this patient has that hypoglycemia, documented postprandial lower than fasting levels, now I am thinking about what are his fasting plasma insulin levels. Has he undergone a 24 to 48 to 72 hours fasting, and have I seen a plasma insulin by glucose ratio? And then I am thinking about something else, because an insulinoma kind of a patient is rare, not picked up, obese, fat, a tumor, the only tumor where there is no weight loss. So I'm worried right now. So nothing against you in this thing.
So that was the first thing which we wanted to rule out for her, was that she doesn't have a insulinoma or anything at all. So she had the basic initial evaluation with the fasting sugar and fasting insulin level, postprandial insulin levels, and I was also on the verge of getting her admitted for the 72-hour fasting protocol. So because as such, we need to have for hypoglycemia, we want to have a sugar level of below 70 absolutely before we say that okay, it was a documented hypoglycemia for this individual. So did the initial basic evaluation, which came back fine, but still she had the clinical features with the with the pigmentation around the neck and everything. And so we had her on the trial of the diet for a few days. It's now been around, I think, 8 to 9 months so I saw her for a follow-up recently, and she had been doing fine, has managed to lose some weight and not having, so both symptoms, they completely stopped within that 3 to 4 days of the diet intervention itself. So yes, that's the first thing that we would think about is the insulinoma. In fact, when she came initially, it was a thing that okay, we will need to evaluate you for insulinoma with the 72-hour fasting protocol.
Ma'am, actually he had 2 more questions, but he asked Dr. Hemi to refer one case.
In one of your slides you showed that the LDL cholesterol also went down with this medicine.
LDL उतना change नहीं था, sir. Triglyceride में था, triglyceride, not the LDL sir.
What are the indications of obeticholic acid? It seems it is replacing UDCA.
Not using it at all.
We are seeing a lot of prescriptions in which earlier patients were taking UDCA, now they are being prescribed obeticholic acid.
Ma'am, it really does not have much of clinical benefit at all, so we are not using it in clinical practice. No significant recommendations for that either.
Not in NAFLD or in any other thing related to liver?
कोई फायदा नहीं है उसका.
Dr. Mangla sir. Pankaj first.
One question. A patient with grade 1 fatty liver and LFT is abnormal, and another patient with grade 1 fatty liver with marginally deranged LFT or organ enzymes, biomarkers are negative. So both will be treated with medication or without medication, or just conservative treatment with diet control,
So
weight loss.
diet and exercise is not optional for anybody. So be it grade 1, 2, 3, whatever, be it liver enzyme based or normal, so that has to be there. Regarding the medication part, we can have two options for the person with raised liver enzymes, depending on what is their dietary history and everything. Whether we want to give them a trial of this diet and exercise alone for 3 months and then consider adding medication, or depending on the degree of elevation of LFTs and the other clinical features, whether you want to add it on straight away. So say supposing if I add on to that cocktail that okay, this person has grade 1 fatty liver, has elevated liver enzyme, non-alcoholic, and has borderline high fasting sugars also, I would probably have a low threshold of starting this person on saroglitazar and along with diet and exercise and see them back in 3 months time.
In case if it is grade 2, definitely it has to be treated, but at least grade 1 with deranged enzymes then needs to be treated with medication.
So again, as I said, depending on what is their baseline dietary and physical activity level, we can, and again what is the baseline liver enzyme levels, we can look at giving them a trial of diet, exercise, conservative management for 3 months time and review at 3 months time. And if there are other, add-on features like, high sugars, or we have high triglyceridemia along with that, or, those kind of features, or if supposing they're already very particular about their diet and exercise. That person is a fitness freak, it still has ended up having this, then I would probably start it off straight away.
Excellent question, Pankaj. Dr. Mangla sir has a question on the overall aspect of this.
I just wanted, is the rise in with a fatty liver on ultrasound report, like maximum reports you report as grade 1, grade 2, whatever ultrasound thinks about it. And if they have some rise in enzyme, does it correlate with the steatohepatitis?
Yes, sir.
Always. If you do biopsy of these patients and they have risen enzyme, all of them will have steatohepatitis.
The reason why we would be having the raised liver enzyme is because of the inflammation.
Agreed.
So not every patient that we are going to be doing a biopsy for. So
short of these enzymes, do you have any other parameter for steatohepatitis? Because I heard some talks where they say that these raised enzymes do not collaborate with. Short of biopsy, it is very difficult to say.
Yes, but again, I think we still need to get to that.
You can't biopsy
so the basic thing with regards to diet and exercise has still to be there. And it gets down to whether we want to add a medication at that point of time or not is what we have to think about.
Saroglitazar you give lifelong, or for how much time will you give?
So it is typically needed long term, because the basic problem is that this excess fat and the obesity issue in itself is a chronic medical problem. And even in people who are otherwise underweight also, if they're having issues with increased belly fat, increased abdominal circumference, which is then leading on to issues with fatty liver, it is something which they are going to need long term. It is not a 6-9 months thing.
But is it some kind of, because we have millions and millions of people having fatty liver. I think it is some kind of a genetic predisposition in people who will go on to NASH. Like, all IPF cases don't develop bronchogenic CA. Like all, smokers don't develop bronchogenic CA.
Just like all obese people do not go on to have issues with diabetes. And there are thin people who would go on to have issues with type 2 diabetes also.
Yeah.
So, in fact, actually, when we look at diabetes incidence also, particularly in India, most of the people will actually be in the normal BMI category. But the problem is that the belly fat is much more for Indians. So we have that belly fat which contributes to the bigger problem in India compared to the Western population where much higher BMIs are more contributing.
All patients with ultrasonologically reported fatty
Sir,
liver,
problem बढ़ गया है इतना ज़्यादा वो. So I'm not saying that everybody who comes with a fatty liver on ultrasound report has to be on this drug, but everybody has to be having good diet and exercise.
That's what I'm saying. It's a chronic illness.
It is a
chronic illness. You may do it for 3 months.
So
you may do it for 6
the
months.
other thing
Like
also.
diabetes, they all become lax, isn't it? Like all chronic illnesses, they become lax. Most education has got nothing to do with it. So that's what I'm trying to say. Millions and millions ultrasound is reported. There is something more to it.
Ma'am, can I ask you a very honest question? If I am overweight and if I am determined to lose my 10% body weight by my own means, do I still need semaglutide?
No, then you won't.
Then I no need to call Mr. Rajesh Khanna or even Amitabh Bachchan.
So that is why you would work on the prevention part much more. So चाहे पतले हो चाहे मोटे हो सबको अच्छा खाना खाना है.
Ma'am, Dr. Podar has been, and Dr. Podar wants to ask.
I think Dr. Mrs. Chakrabarti asked about the role of UDCA. One of the indication of UDCA used to be pure cholesterol stone, where there was no patient was not fit for surgery. Pure cholesterol may be a rare. Still, you consider it UDCA in pure
Sir,
cholesterol?
I don't tend to see those kind of patients, so I will not be able to comment on that.
And the second indication was in obstructive jaundice symptomatically. Sometimes we used to say, not in cirrhosis of liver sort of thing, but obstructive jaundice is some symptomatic leaf we used to use UDCA.
So sometimes even on post-bariatric surgery patients, at times they would have the patients on UDCA for a few months after bariatric surgery, especially if they are not doing the cholecystectomy at the same time.
And last question, role of coffee in liver disease. Because I have heard one gastroenterologist, he said coffee has good role in this type of disease.
Sir, we don't have significant studies regarding that as far as my knowledge is concerned. So like black coffee, white coffee का भी studies है, there are studies about green coffee also. So आजकल तो पता नहीं क्या क्या.
Our patron sir has a question. Dr. SK Mathur sir has a question.
So I have one comment. Very nice talk, very well explained everything about the insulin now. But lifestyle management is the hallmark of different all metabolic disorders, and Sushil says and Dr. Tulsi says. Now, bottom line is that he has brought up the topic that everybody will get an ultrasound done. The people get ultrasound of their own. They don't come to doctor for that. Pet mein dard hua, ye hua. And fatty liver, grade 1 is a very common find. Now we have to see overall the patient, not the one aspect of fatty liver, the weight profile, the lifestyle, the dietary habit, and any other comorbidities there. So hallmark is lifestyle management. But when do you start medicine like this? And the liver is there. Normally double the level is acceptable in my opinion. 3 times the normal level should be start treatment. Is that right thing?
Yes, sir. And again with that also, as I was talking about earlier, say supposing if we have somebody, 25-year-old person working in a corporate, sitting in the office from morning 9 o'clock to 9 o'clock in the night, having all sorts of junk all throughout the day, that person is very motivated, non-alcoholic, and is ready to transform things for himself, then even if the liver enzyme levels are 4 times the upper limit, even then we would be like, okay, let's wait for 3 months time and see you back.
So lifestyle is the hallmark of the treatment. Thank you so much for it, sir.
Thank you.
Isn't the reason it is being over-reported? Like every ultrasound has a tendency to...
I think we would like to think that it is over-reported, but I don't think it is over-reported. The way we are seeing the incidence of diabetes increasing so much, this is actually going hand in hand. There is this so much harm that we have done to ourselves as humans over time. the way our lifestyles have changed over the decades, and I'm much younger than you. मैंने तो 4.5 decades देखे, you've seen much more. How our grandparents, how our grandmothers would do stuff at home. आजकल तो सब्जी लेने के लिए भी नहीं जाना, घर के बाहर भी नहीं जाना पड़ता. It's delivered at doorstep.
Dr. Hemi
has fatty liver in at least 80% population.
Dr. Hemi Soneja, ma'am, we have some wonderful questions here, ma'am. They are waiting for you.
I was waiting for
Ma'am, did you ever appear for your endocrinology examination?
Yes.
Okay, so I would like you to have some nostalgic memory of that exam.
And he said, best for the last.
No exam, very simple questions after some complex questions from friends and colleagues. Dr. Soneja, this is a wonderful talk.
Thank you.
So, as Dr. Chauhan said, the renaming of NAFLD to MASL and NASH to MASH. See, this is a paradigm shift in the way we understand this condition and the way we treat this condition today. So, I'm just going to ask you about the biomarkers and the drugs we have today. So, talking about the biomarkers. So, would you say that the screening, non-invasive screening is probably paramount here, like the FIB-4 score and the study index, the FIB-4 score index, less than 1.3 would be a low risk, and 1.3 to 2.6 would be intermediate, and more than 2.6 would be high risk for patients progressing to fibrosis. But are there some pitfalls to the FIB-4 score, ma'am?
So, it is indicative, it is the negative predictive value is better compared to the positive predictive value for that. So, if somebody is falling in that moderate or the high risk, then yes, we have to evaluate further. But if they're falling in the low risk, then we don't need to do a fibroscan for them.
Right. So I was referring to the, the age. See, it decreases in advancing age and is 30% at age 65 and beyond. Also in patients who have low platelet counts, these from etiologies which are other than portal hypertension. So many overestimate FIB-4 score and lead to false positives. So that is as far as the FIB-4 score is concerned. Dr. NK said yes. And what about the APRI? The AST to platelet ratio index and the NFS, the NAFLD fibrosis score, all can play a role, as a red flag for early identification of patients of high risk for fibrosis. So these are biomarkers. Apart from this, what about the ELF test?
So,
this is very well validated. Dr. Chauhan.
Dr. Shubham can get on.
Anyway, let's proceed.
I am not doing that myself. Dr. Shubham, can you give an
Dr. Shubham, can you dwell on the ELF test?
last time
Yeah, I asked you and you bypassed it.
So I am doing the same, I am having high calorie diet.
So Dr. Soneja, this is very well validated today. The three markers, biomarkers, direct biomarkers, talking about the hyaluronic acid and the pro-collagen 3 and the TIMP1. See, these scored more than 10.5.
Sir, these are not used in clinical practice.
No, they are used now.
Not so much. So, pro-collagen are not used.
Today, these are being used and they have been very well validated.
But sir,
I learned about that. I didn't know. I learned about that.
We don't have them available for clinical use per se at this point of time.
Okay, let me proceed further. What about transient elastography and MRE, especially patients who are obese, like Dr. Kalra. So MRE for patients who are obese. Just dwell on this.
So MR elastography will be something which is going to be kind of, midway or maybe before doing a liver biopsy for somebody.
Absolutely.
So, if we have a high clinical suspicion, then, in clinical practice, they're probably better off getting the liver biopsy done instead of getting an MRE. At the same time, if we have somebody, say, supposing on, anticoagulation or something, in that case, we would not want to do a liver biopsy for them. So if we have any contraindication to liver biopsy, we can look at doing the MRE, but it again is going to be an indirect, way of evaluating things.
Lancet hepatologist last year talked about lipoprotein little a. Where is Manish?
We are equal. Now we are equal.
Manish?
Sir, I'm here, sir.
Okay. He's a big fan of lipoprotein little a and circulating lipoprotein A with transaminitis. See, it itself is a biomarker for progression to fibrosis. Dr. Manish, please say that. He says yes. And finally, management. Dr. Chauhan talked about it. So the most recent AAC guidelines suggest that the LSM is the standard of care here. But likelihood of success is often modest because adherence is a big problem.
It's almost like, likelihood of curing diabetes.
Right.
So that's the bottom line.
Yeah, absolutely.
But what we have to look at is, even if we are being able to delay or halt the progression of condition, even then we can buy in quite a few years for an individual. So if we can halt the progression of that fatty liver from progressing on to developing issues with diabetes and other atherogenic things, that will help.
So Dr. Chauhan says to wind up, so probably last 2 minutes, Dr. Chauhan. So weight loss is the established strategy here. Even if you lose 10% of your body weight, big this thing. So finally about drugs, metformin.
So metformin not so much for fatty liver.
AAC is not recommending this because histological appearance is sugar. Does not change with metformin.
So, and not even for weight loss also.
Absolutely. So, SGLT2 inhibitors, GLP-1 agonists, the GLP-1, the GIP agonist, not to forget the triple agonist, which is coming next year by Eli Lilly. What's the name? It's a letter to try. Letter to try. This is going to be a game changer. Thank you, ma'am.
I'm the last person. Thank you, Dr. Tulsi sir, for reminding my mistake. But mind you, sir, I am obese but healthy. I don't have any fatty liver, and my liver functions are better than Dr. Tulsi. I can vouch. Yeah. Plus, those who are normal weight and fatty liver, they fare badly compared to obese like me and no fatty liver. Sure. Well, I wanted to draw your attention to your case about higher fasting than eating. So, is gastric dumping also a point to be considered?
So, we wouldn't really expect gastric dumping unless if there has been any other surgical.
And I hope the patient was not on medicine?
No, she was not on any medication.
Any medicine too?
So it was not so much a gastric dumping syndrome that she was having.
But this also goes like this. And plus, what I have my concept, fasting is controlled by different pathway, and we know the different pathway. It's your response. My one query, whether you go for insulin testing or C-peptide, because I read somewhere C-peptide is better.
So we need to check both.
Insulin testing includes the pro-insulin also at times.
So for that kind of patient, yes, we can check the C-peptide levels also.
One more point I want to share with friends. Those who are absolutely healthy, even they should eat mindfully.
Absolutely.
Because if they don't eat mindfully, it will affect the children and grandchildren. That's why I have modified my ways recently. Maybe it is too late, but never too late to man. My last question is, triglycerides are now being very much in the favor. Otherwise, I remember 10 years back, triglyceride was nothing. And now, triglyceride is taken over LDL. And low HDL, high triglyceride is the Indian phenotype.
One of the good things is that it is very modified. Compared to LDL, the influence of diet on triglycerides is much more. So the degree of improvement in triglycerides that you will see with diet modification is going to be much more significant compared to the effect that it will have on LDL.
So, with the advent of MASH to MASH, liver is now considered to be responsible for diabetes. So, diabetes is a liver disease. Thank you.
Excellent, Dr. Kalra, Dr. Tulsi sir, and the wonderful question.